Okay, this is Bill Nelson here, Director of the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins, and we're taking on the first of what will be three panel discussions on issues related to cancer health disparities and equity and justice in cancer treatment. And I can say that Peter and Judy Kovler, who've been long-standing philanthropic supporters of the Cancer Center, have really challenged us to take on these kinds of issues in ever more meaningful ways. And as the director of the Cancer Center here at Johns Hopkins, I was also a contributor to the recent American Association report to the nation on cancer health disparities that was presented last month to Congress. And of course, Martin Luther King very famously said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I think all of the panelists will agree. We have with us today Akila Viswanathan, who's a radiation oncologist, a director of radiation oncology, molecular radiation sciences at our cancer center. Ashwani Rajput, who's a surgical oncologist, director of our cancer center service line in the National Capital Region. And Otis Brawley, like me, a medical oncologist, and he's a Bloomberg Distinguished Professor and the Director of Community Outreach Engagement for the Cancer Center. Now, our National Cancer Institute has defined cancer health disparities. There's many definitions, but theirs is adverse differences in cancer measures such as the number of new cases, the number of cancer deaths, the number of cancer-related health complications, survivorship and quality of life after cancer treatment, screening rates, and stage at diagnosis that exist among certain population groups. And the ones they're most concerned about are certain race and ethnic groups and differences in ancestry, certain socioeconomic status groups and those with limited insurance, people with disability, people from the LGBTQ community, people who live in specific geographic areas across the country, including Native American reservations and rural areas. They're concerned about immigrants, refugees, and asylum seekers, and concerned about children, adolescents, and the elderly. And this is a very important area. There's an estimate that 34% of all cancer deaths could be eliminated, for instance, if just the socioeconomic disparities were adequately addressed. And similarly, there's an estimate from the period from 2003 to 2006 that if we eliminated health disparities, we would reduce direct medical costs by $230 billion and indirect medical costs by $1 trillion just over that interval. The first thing I thought we could talk a little bit about is access to care in terms of access to cancer screening. Now, breast cancer, cervical cancer, colorectal cancer, and prostate cancer are the four major types of cancer for which screening tests have been developed that are used to screen people who are generally healthy and at average risk for cancer. So why don't we start with Akila Viswanathan. You're an expert in the treatment of women in particular with gynecologic cancers and the like. Cervical cancer is one of the ones that we have screened for. You would think with pap smears and whatnot that we shouldn't have any cervical cancer. We still have it. What is the story with cervical cancer screening, access to screening, and what you see in your cut of the disease?
Yeah, thanks so much. And hello to everyone. Really happy to be here and part of this great panel, and thank you for all of your support. Cervical cancer is a disease that I think everyone's heard of. It impacts over 600,000 women worldwide, about between 13 and 14,000 in the United States every year are diagnosed with cervical cancer. So you can see the discrepancy. It really is a disease that occurs because women don't have either access or for some reason are unwilling to go seek medical care. So everybody's heard about cervical cancer, and it used to be in the 19th century, it was the leading cause of death in women. In the 1950s, pap smear screening was developed, and so we saw a rapid decline in the number of cases. So we know how to gain control of this disease if women are proactive and get routine annual exams and are seeing their doctor for pap smears. That has evolved to include HPV DNA screening, but we know that the factors are not only pap smear screening, but that family sizes decrease. So by women having fewer children, there's actually a lower risk of cervical cancer. And we have seen, of course, easier access as medical care and hospitals have flourished in the community and in certain less urban areas. But clearly factors that influence lack of access are poor. People in communities where they just don't either have transportation access to a medical center or a local, some kind of healthcare provider in that community. If someone's first language is not English, they're much less likely to understand or seek medical care in the community, even if it exists. People that are immigrants, people that are undocumented. Interestingly, in the LGBT community, there's decreased screening, and also those that are obese. Some of these may be just a hindrance to receive healthcare. Some of it may be a hindrance to take care of oneself. But clearly, there's a lot of disparity in access purely by where physicians and healthcare providers are located in the country, and then how people can gain access to those areas. So cervical cancer screening is very much about that, and we see a significantly the incidence rate, which we measure per 100,000 in the United States, is 7.5 per 100,000, but in the Hispanic community in the United States, it's 8.9 per 100,000, a very significant increase, and in the African American community, it's 8.3. So just numbers put to the fact that if women don't get their screening, whether it be Pap smear or HPV DNA, their test, that they will then end up with much more advanced stage disease, which then results in a survival decrease. So because women don't seek that Pap smear, they only present when they have symptoms, and those symptoms are large, sometimes incurable masses. Now, the women that I see that present have all of these issues and are coming sometimes with very significant histories of pain or other medical problems that then have been going on and get to the point where they have to present to the emergency room and are diagnosed. And some of them can still be treated curatively, and some of them, unfortunately, will only be able to receive palliative care because of the lack of screening.
So can you comment quickly, just a follow-up question, is that one of the aspects of screening for cancers, and this is true for each of the screening strategies, and certainly true for Pap smear screening, is that when a positive screen is the result, there's an escalation in need for technology and expertise, right? You have to go on to colposcopy and often that's also a barrier. Is that right?
Absolutely. So, someone may get a screen, but then they have to get a follow-up. They have to have a phone or be able to receive a message that the screen was positive, just like you would for any disease with a test, but then you have to return for the follow-up. And sometimes, for some women, single mothers that have other issues, getting their follow-up test is so low on their priority list that, getting food for the table that day or the next day is, numbers 1, 2, 3, and 4. And so, going to see your doctor for your follow-up after a Pap smear is unfortunately a hard challenge and difficult to fulfill. And then that includes, as you mentioned, the colposcopy, follow-up exams that show after a biopsy that surgery may actually be needed. And surgery, nowadays much better. It's a hysterectomy. It's called a radical hysterectomy, where it removes some of the adjacent tissues, but it also results in potential morbidity. So, might need an overnight stay. You have to have, childcare. You have to have, and I always say the number one reason why I see women who have access to screening getting diagnosed is that they just have young kids and aren't taking care of themselves. So they're just not going because they're going to the pediatrician's office a lot. So, it runs the gamut. There are issues with access in all communities, but particularly in those that just don't see a doctor at all.
So Ash Rajput, Akila Viswanathan hinted at something that you can expand on for us, which is when we use screening and detect or diagnose a cancer, it's often small, and there's been innovations in radiation therapy and in surgery to make them easier to do, less deformative. You can do a lumpectomy and not a mastectomy. You can do a conization and not a radical hysterectomy. Talk to us about the stage at diagnosis for people who've been screened and then adequately followed versus people who just show up with symptomatic cancers when they can't take it anymore. And what does that mean to a surgeon like you?
Well, thanks. And let me echo Dr. Viswanathan's sentiment and thanking everyone for joining us today for these important conversations. To your point about the early screening and what it means in terms of treatment, um, I can use colorectal cancer as an example. For example, all the colorectal cancer starts in a polyp. So if you come and you get screened and you can get that polyp out with an ambulatory visit to the endoscopist, where you can get a little bit of sedation, have the polyp removed and go home. Because that polyp's never going to turn into a cancer because it's in our pathology colleagues' bucket. But those people who don't get screened and come at a later stage, as you said, Bill, it means that it may need more treatment. So if it's in the rectum and it's accessible to a microsurgical technique that we can remove, that's fine. But oftentimes what we have to do is remove that entire portion, or the colon or the rectum, and the draining lymph nodes. Now, the pathway or the steps that the cancer takes is then to spread from that organ to the lymph nodes. And if the lymph nodes are involved, then it's not just surgery alone. Then we need our medical oncology colleagues to give the chemotherapy. And that can be for 4 to 6 months. So not only is that more treatment, more time away from family, but also increased cost. And what we find also is that for those patients, and oftentimes our Black and other minority patients of color present at a higher stage of disease. And if patients present at stage 4 or with metastatic disease, about 40–50% of those patients may go on to receive additional surgery, for example, a liver resection or a stage lung resection. But then again, that's more treatment, more cost. So the benefit of that screening is really important. And Bill, you alluded to when people show up in the emergency room. We're just finishing a manuscript that we looked at this data in New Mexico, where I came from. And we were a safety net hospital. And we were often getting calls to the emergency room for either a breast cancer or an obstruction from a cancer. And we looked at a 6-month time period, and we found that we were at least diagnosing cancer every day in the emergency room. And the patients who present to the emergency room symptomatic, 50–60% of those patients actually presented at stage 4 disease or with metastases.
And that's fundamentally in an incurable stage. That tendency, as you mentioned, to present with higher stage cancers seems to be, almost a signature, if you will, of cancer among the underserved that have poor access or functional access to healthcare. Now, Otis Brawley, I've known you for almost half my life, and you are one of the world's experts in how we should best use screening. And it is not an easy game. There's a tendency for over detection, over screening, over diagnosis, under screening, which means we need to do smart screening. And the minute we say that, then we worry, are the vulnerable populations that we talked about able to take advantage of the best that screening has to offer? Otis.
That's right. I spend a lot of time looking at screening and looking at efficiency of the medical system, of the healthcare provision system. And we're fortunate at Hopkins that we're very wealthy in terms of resources, but many hospitals, many clinics across the country are not. And that's where we have to worry about efficiency in screening. Let's take the cervical cancer example. All major organizations recommend that women who should get screened every 3 years or every 5 years, depending on the test that's being done. It's very common that middle class and wealthier women in the United States get that test every year, while everybody's recommending it every 3 or every 5 years. On the other hand, there are about 4,000 people who die from cervical cancer in the United States every year. And that group was studied a few years ago. It turns out that 95+% of the women who die every year from cervical cancer got no screening in the 10 years prior to their being diagnosed. So here we have people getting it too often and people who should be getting it just once in 5 years, never getting it at all. The same can be said in prostate cancer. In prostate cancer, we have a lot of men in their 70s and 80s who are religiously getting screened for prostate cancer, when all the major organizations actually recommend that men age 50 to 70 or so understand the pros and cons of prostate cancer screening, and then make a decision as to whether they want to get it. And that brings up the issue that screening can be harmful. The screening test, the diagnostics brought about after a screening test is positive, it can be harmful. And there's actually a death rate associated with overuse of medical procedures that we have to try to minimize. And finding that balance is really, really important. Last thing I'll point out, I really like people to get into a program of screening as opposed to a one-off. So frequently people say, get a colonoscopy. They should get into a program where they get regular colon cancer screening over a period of time. It's especially important for breast cancer, where we want to look at the mammogram from last year and the year before, get all the mammography at the same place, and get it in a regular routine program of screening as opposed to a one-off.
So we've been talking about a medical system that doesn't always provide access to the resources that are needed sufficiently, that the people don't functionally use. It's a functional access issue, and then that may have uneven quality in what is available. And this is very true as we'll move on now to cancer treatment and access to cancer treatment. Now, most patients with cancer end up treated with some combination of surgery, radiation therapy, cytotoxic chemotherapy, new molecularly targeted treatments, which requires gene testing to administer, and immunotherapy is sort of the newest kids on the block. And it is pretty clear that people from certain population groups, including racial and ethnic minorities, poor people, and the like, are often less likely to receive what we believe should be the standard of care recommended for the type of cancer they have. And many trials have suggested that race and ethnic disparities, for instance, for different kinds of cancers, like prostate cancer, are very famous from the radiation therapy folks did a trial, that if the people get the right treatment and get the same quality of treatment, the outcomes or the differences associated with African Americans and Caucasians, in this case, disappear. So we know that if we can deliver the right quality of care. So Akila, radiation therapy is not a minor business. It's very sophisticated instruments that require sophisticated uptake, a whole branch of physics to make sure that the dose is generated, it's the correct dose, it's deposited in the correct place. There are instruments spread throughout the country. Are there places where there are not enough radiation therapy instruments, places where there's too much? How's the quality? How's it variable? Can we get everyone access to the radiation therapy they need today?
Well, I wish. Like, let's start with, think big. We're going to get radiation to everyone that needs it. And right now, that's about 50% of the US population that has cancer, of cancer patients. So of 308 million people in the US, 85% live in metropolitan urban areas, 15% in rural. There are 2,500 radiation oncology facilities and 3,700 linear accelerators in the US. 9% of the facilities are in rural areas, and so we have a discrepancy between where people are and where those machines are. And it's clearly not something where we have large centers in rural areas. These are usually one machine. If that one machine goes down, there's very little backup or place. So someone will have to drive to a metropolitan region, and that might be 5 hours away, depending on where people are. So there's clearly a difference, and that results in a survival difference for patients. So we see that we talked earlier a little bit about a survival difference by race in cities, but we also see that with the rural versus urban populations in the United States. So I think it's a challenging question because maintaining those machines requires a lot of staff and training and things like radioactive sources that have to be monitored by the government. And, so that's much easier. And I think the hub and spoke model works well. If, we had the rural centers aligned or affiliated with the major urban centers, and that was kind of structured from the government, then we'd be able to share in the burden of providing that care and getting those resources, having adequate physics staff or for radioactive sources for brachytherapy or things that people need in order to get proper cancer care locally. I think the other thing is just, there's a lack of transportation. Somebody wants to come in to the cities. They don't really feel comfortable, even if the city's an hour away, because it's just the big city and they really have never gone or never been. And, it's far to go for a lot of people. So providing kind of a network or systems by which people could reliably say, oh, look, my primary care told me I can get this form of transportation, some Uber, some bus, some whatever it may be, but, count on there being a net to catch people that may get stuck because of where they're living in the rural community.
If I could ask a follow-on question, one of the things that's been remarkable about radiation oncology as an enterprise over the past several years is that the rate of innovation in the technology has been truly spectacular. And basically generally the ability to ever aim the radiation ever more precisely at just where the cancer is, sparing more and more of the normal tissues. Lots of jargon names that we won't go through for our listeners, but those things are coming fastly and furiously. Is the dissemination of those technologies, proton radiation therapy is one of them, but the intensity modulator, 3D, all that, is that adequately disseminated across the country as rapidly as you'd like to see it?
It's the machines are capable. If you were in the community and you had a machine, those machines should be capable of doing some of the technology that's come out, say, in the last 20 years, the IMRT, the VMAT. It's that the physicians that work there may not have been trained in an era to have learned and feel comfortable. And most people don't necessarily retrain to learn how to do all these new things. So it's a mix. Some of the newest on the horizon technologies are talking about depositing dose in seconds, not in minutes. And, those what's flash or quick, super fast radiation treatments will mean that, you may not need to necessarily even stay for multiple treatments. You could get, all of the dose in 3 seconds rather than over 35 days. So, how that technology evolves and where it's going to be most available, we'll see. And that, again, that technology is going to be held at first, of course, where it's developed in the cities. But I do think that importing those new technologies into the community will be essential, especially in low and middle income countries and in rural environments in the U.S. Bill,
I'm muted. Sorry, I missed. I try to keep myself down in case I belch or something. But Ash Raj, but one of the things that amazed us when we started building these multidisciplinary clinical services for various different diseases is our pancreas cancer one was following everyone they took care of. And they discovered that about 25 or 26% of everyone that arrived with a diagnosis of pancreas cancer was not diagnosed, staged, or graded correctly. These are the major decision points of what treatment we use and how we use it and when we use it, and yet they were inaccurate or inadequately done. And this created instantly a worry that this was a problem across the country. Again, a source of variability in the quality available to people and vulnerable people typically not having access to the highest quality. What about staging, grading, and what difference that makes to a surgeon or the beginning of cancer treatment in particular?
Sure. And it's incredibly important because in this day and age, we don't just treat with one modality most of the time. And that's why my colleagues in medical oncology and radiation oncology are on the panel as well. And so it makes a difference. So oftentimes, we'll say where you get treated matters, and because where you have the expertise, and what Dr. Viswanathan was saying about whether someone's trained in that area or is kept up in that area. Dr. Nelson, you mentioned the pancreas patients. Well, first and foremost, that's a very scary diagnosis for anyone to have, and then they come in with that fear. But oftentimes it can be very difficult to distinguish a benign process in the pancreas, like a pancreatitis that's causing an obstruction that results in the jaundice where the patient turns yellow, or if there's truly a cancer-related mass. And that in our pancreas multidisciplinary clinic is something that has to be ferreted out by our colleagues in pathology. And so that can make a real difference. And I'd cite you another example too, just not in pancreas, but when our multidisciplinary colleagues are managing rectal cancer, it makes a huge difference. So we know that treating patients with chemotherapy and radiation up front for a certain stage of rectal cancer has a benefit in reducing recurrence rates. Well, we need to know how deep that tumor penetrates into the bowel wall. And we do that with either MRI, which is dependent on the software the institution might have, and the radiologist who's reading it, or we do it with a transrectal ultrasound, which is operator dependent. So you have to have that sophistication to get the accurate diagnosis, because if you get diagnosed at a higher stage than you truly are, you would get the chemotherapy and radiation, which you may not need. So you wouldn't have got that benefit of that treatment, but you certainly would have got the side effects and potential complications. So it makes a huge difference in our decision-making points to have that accurate stage at the time of presentation.
You're muted again.
I did it again. Otis Brawley, when you went down to Atlanta, I can remember shortly after that having a significant conversation with you about the quality of medical oncology care and how variable that was across the country. It was something you were concerned with at the time. You've had a chance to look at this and look at the patterns of care, patterns of incidence and mortality across the country. What can you say about this variability in quality that seems to be under the surface of vulnerable populations like poor people, people in race and ethnic minorities?
Yeah, there's quality of the medical care that's given by us in the profession, and then there's the quality of consumption issue. Adherence can be a huge problem where people are offered good care and then they drop out. For example, of women getting radiation after lumpectomy for breast cancer. In certain parts of the country, especially in certain urban areas, 30% of women drop out of the 6 weeks of radiation, usually in the second week. And when asked why, it's usually, it doesn't hurt, so how can it be helping me? And I spent so much time traveling to the radiation therapy facility, and then the machine is only on for less than 2 minutes after I've spent an hour and a half going both directions to and from, And so that's a quality issue. One of the issues I ran into in Georgia is many medical oncologists actually skimped on dose of chemotherapy because the patients were obese. They were afraid to give the dose of drug that was called for because they were afraid that they're going to get a bunch of side effects and the patient would become non-compliant because of the side effects of chemotherapy. But there are a number of issues one runs into. High volume centers that are well organized tend to provide better care, be it chemotherapy, radiation, or surgery. But one study that I was involved with a couple of years ago shows that poor people who go to certain high volume centers, the pathologists are overwhelmed, and so they don't stage the colon cancers as well as in centers that are less overwhelmed. So you have to worry about that. Again, we get into the efficiency of how the system actually works in providing care.
So there we've talked about access to care, both, again, access, but also access to high quality care and the uneven distribution of access and care quality across the country, undermining the chance to take better care of poor people, of people in vulnerable ethnic groups, immigrants, et cetera. One of the growing things, it's like one of the great stories in cancer medicine, I suspect you'd have to say, is this growing number of cancer survivors. And the number, every time you hear it, the next time you hear it, it's higher. So it's somewhere, it's not quite 20 million yet. I suspect it's somewhere between 14 and 18 million, the last set of numbers that I heard. That, by the way, should be a political group, and we get different people elected to office that would support cancer research. But in any event, people who are cancer survivors and long-term cancer survivors have wholly different kind of health concerns and health challenges. And we're just learning, I think, how to take better and better care of them broadly. But of course, as we do so, we're risking, I think, exacerbating some of the very disparities that we're trying to eliminate. And so maybe start with Akila. Akila, there are known late effects to radiation therapy. There are known late effects to chemotherapy, leukemia and the like. Talk about these late effects and how that's involved, how radiation oncologists, medical oncologists and the like watch over people are often the experts at managing the late effects because they're the ones who understand them the best. And about how that may or may not be as well accomplished, again, in the setting of disparities.
You know, I take, for example, breast cancer because it's just very common among women, and what some of the late effects may be, and just how it's monitored, and what some of the reasons are that people don't go for their monitoring. So the first is what we talked about before: women that are poor or just don't have a hospital or healthcare facility close by just don't know that late effects can occur. What happens with radiation? So for breast cancer, one of the key late effects may be cardiac disease. And that happens like 20 years later, where the coronary arteries that sit underneath the breast, just in the heart, may get hit with radiation and get scar tissue, if you will, in that area. And that happens anywhere where radiation is given. You can get this scar tissue buildup, and it actually gets worse over time. And so the heart attacks 20 years later may actually be a result of radiation. Sometimes those occur earlier. Young women that get radiation to the chest may have an increased risk of breast cancer itself. So for Hodgkin's disease, we use radiation, there's an increased risk of breast cancer. I think that, there are other side effects related to chemo. For example, we talk about osteoporosis and bone loss, and all of these things require knowledge, somebody who's aware that the two are related, and more frequent monitoring. So, I think, so for example, all of these treatments can affect fertility, but women may not necessarily realize that they might be at risk for premature menopause or for some, changes that occur, like the bone loss that requires a bone density scan. And all of those things require an actively engaged and knowledgeable physician that's followed a patient for a long period of time. So if you're going and not going to see your regular physician, but you're going to a clinic, they don't know you. They've never, or if you're just using the ER for the problem that arises at that moment, if no longevity, no one's going to pick up on that fact that, the lack of follow-up care has really impacted your current, whether it be a bone fracture or heart attack or, any of those things that could potentially be prevented by early interventions. And so survivorship is absolutely key, and trying to mitigate the side effects. So getting on, bone strengthening medication if someone has had chemo and resulted in osteoporosis or had radiation damage to a bone. Those are all really important things to think about.
So what you're arguing is very much what Otis Brawley was saying about screening. What is really needed is a program of survivorship care that involves a sustained interaction. And these things are harder, or historically been hard to accomplish in environments where people are poor or have inadequate access to the correct kind of healthcare. Ash, turn to you. One of the things you follow people for, not only late effects, but the cancer they have, would it recur? But the other is that someone whose lifestyle, inherited factors, et cetera, conspired to turn one of their colon cells into a cancer, they have more colon cells. So they might get another colon cancer or a different kind of cancer. This would be a group of people to watch closely and use screening and other tools more effectively for. What about that in this environment of people with inadequate access to sustained medical care?
A great question, because the guidelines or the standards that once you're diagnosed with a cancer, and what I joke with my patients is that I hope you like me because you're stuck with me, because I'm going to see you every 3 months, for the first 2 years, and then I'm going to see you every 6 months until we get to year 5, and then you're going to see me once a year. And the reason being is that if something is going to recur, the likelihood usually is that higher that it will happen in the first 2 years. So depending on the type of cancer, it may be a specific blood test, maybe some kind of imaging, and a physical exam, because we want to find that recurrence sooner than later, because if we have a chance to act on it and cure the patient of that recurrence, that's of the most benefit. And so that's why we do these, but that requires a program too of surveillance, right? So once you get to the 5-year, you may graduate to our survivorship program, but we also have to have this a surveillance program for these patients. So you can imagine the cost and the mental anguish maybe of, I got to get a scan, I got to come back for that scan. And so we really need to work with our patients, not only for those hardcore medical tests, but also the psychological impact of the surveillance, right? Every 3 months or every 6 months having to come back to the cancer center. But that takes resources as well to put those programs in place. And like we mentioned, not every hospital or not every clinic has those capabilities.
So Otis Brawley, you and I were genitourinary medical oncologists, and I remember we had, as an enterprise, dug ourselves a deep hole where we found that when a man would show up and be diagnosed with prostate cancer, at that moment, the greatest threat to his life was that he would have a heart attack.
That's right.
And he would get surgery and do well, his PSA would go away. It would come back, and that day he would have recurrent, metastatic, incurable prostate cancer on that day. The greatest threat to his life was a heart attack. And so what were we doing in those days? We were giving him a drug that would make him more likely to have a heart attack. Just didn't make any sense at all in retrospect. What about these competing health risks, the comorbidities, we call it when we're thinking about the cancer, but this is a person's life. This is what's going to affect the length and quality of life the most, are often things other than cancer. We've got their attention oftentimes for cancer. What about the rest of their life?
Yeah, palliative care is a field of medicine. Many people think it's end-of-life medicine. It's not. It's really how to have good quality of life while being treated and after treatment is finished and one is thriving as a survivor, how to make someone thrive even more as a survivor. And medicine is moving more and more toward looking at these sorts of things. How can we make people have better survivorship? Unfortunately, with access to care issues in this country, poor people, people who have no insurance or less insurance, are less likely to be able to partake in these sorts of programs. But these programs do exist. They are getting better. Virtually every hospital in the United States over the last 10 years has had to adopt a quality of life, quality of survivorship program. Of course, having had cancer is a pre-existing condition. We worry about that for insurance issues as well. Also, I should point out, about a third of all cancers are caused by tobacco use. About 30% of all cancers are due to an energy balance problem. And the energy balance problem is too many calories, obesity, or energy storage, and not burning it off with exercise. So it's a three-legged stool. Not enough exercise, too many calories, and obesity. That, of course, is the leading cause of all the other chronic diseases, diabetes, cardiovascular disease, and so forth. So we really do have to think about the whole person when we're talking about a cancer patient and cancer survivor. And last thing I'll note is pediatric cancer is a special condition. Most of our kids who survive cancer, by the time they are 35 years old, have at least 5 comorbidities that are linked to the cure of their cancer. And we have to improve our treatment of pediatric cancers to overcome those disabilities.
So we've done very well. We've dived into access to care issues related to screening, cancer treatment, and survivorship, and we're pretty much right on time. You guys have been wonderful, and we've explored many dimensions of each of these. In the small amount of time we have left, I thought, this is an election year, without saying we're for one candidate or another. That's not so much the issue. But as we look forward, are there specific policy things, maybe one idea as you look at the world, is there one thing we could do to reduce cancer disparities in the setting of these drivers of access, in the access? What could we do to improve access to high quality care in the country? What is your thoughts? So start with Akila Viswanathan.
You know, the state of Delaware put out a program where they provided equal care intentionally to population with colon cancer and, you know, that had no access and a population that had it. And they got rid of the survival difference. So there's proof that interventions work, and that whether it's state-based or federal-based, these interventions are crucial to ensure that the population has the best likelihood of surviving. Because people living means that they're here to contribute, whether it be to the economy or contribute to us personally, right? It's a fundamental need for us to all care that people live as long as they possibly can to be part of society. And I think that that, you know, program showed that federal and state level interventions are essential, and making sure that the uninsured have, whether it be insurance or some access to healthcare, has to be a top priority for our government.
So Ash Rajput?
You know, I would build on what Dr. Viswanathan just said, and speaking from being in the DC area, we really need to put those resources into communities and think about it as infrastructure, right? So not just roads and bridges, but also healthcare facilities. If we look at the wards in DC, there are certain wards east of the river that are healthcare deserts where we don't have facilities. And so to travel long distances is very hard for those patients to leave their homes or their communities. So that, I think, is one thing that we really need to do, is consider that as part of infrastructure.
And Otis Brawley?
I cannot disagree with my other panelists. They're absolutely correct. We need to find a way to provide adequate health care to every human being, because every human being deserves adequate health care. You know, I spend time with these maps, and I note that for breast cancer, or colorectal cancer for that matter, dramatic declines in death rate from the 1980s onward in Massachusetts. For colorectal cancer, 55% decrease in colorectal cancer deaths since 1980. Go to Mississippi, 15%. They start out about the same place, but one has more than halved its death rate, and one has just chipped away at it just a little bit. We have certain states that have not appreciated providing health care to all of their populations, and it shows dramatically. The other thing that I would focus on is not just treating people or finding people who have disease through screening and then treating them. I would focus on prevention of disease. 30 to 40% of all cancers could be prevented in this country if we focused on getting rid of tobacco use and then focusing on the energy balance problem. You know, many of us, myself included, struggle with this, but I would point out in 1970, 15% of American adults were obese. Today, it's closer to 40%. For kids, it was 4% in 1970. Today, it's 20%. Keep in mind, energy balance is the second leading cause of cancer in the United States, or energy imbalance, I should say. So let's focus on prevention and getting people access to care. You can actually merge them. Access to care, in my mind, involves providing every person with a health coach, someone who can teach them how to eat, how to exercise, and how to behave in a way that they are more likely to not end up needing the services of an oncologist.
So, you know, it's interesting that each of you pointed out there have been analyses of cancer disparities for a long time that have suggested very strongly that changing access to care and these kind of things might have a benefit. But what did each of you go to? A real example that when we did so, it works. And I think when you say that, you have to say yourself, then why aren't we doing it everywhere? We need to. Started off with a Martin Luther King quotation, and a famous one, another famous one he had that everybody knows is that injustice anywhere is injustice everywhere. And I think what you're saying is the same thing true about people with health problems. You know, cancer problems anywhere, cancer problems everywhere. Everybody deserves the right amount of access to care and quality care and a quality of life. And I know you all very deeply believe it. And so this has been a wonderful conversation to start the series. The next one we take on will be social determinants of health. And then after that, what about our workforce? Is it diverse enough? Can it be crafted a way to be sensitive to all these issues, poor people, other vulnerable minorities, language, all kinds of barriers? And we'll get into all those things. So thank you all very much for participating, and all of you for joining us. And we look forward to seeing you, hearing from you, being with you virtually the next time we get together. So thank you.
Thank you.
Thank you.
Oh my gosh, we're right on time.